Welcome to live Q&A with the experts of Rome Foundation. Today's session is titled Gut Microbiota and IBS. I'm your host, Tanya Murphy, Executive Director of Rome Foundation, been serving nonprofits for more than 20 years and a professional educator for over 30. I'd like to introduce my co-host, Dr. Douglas Drossman. He is the CEO and President Emeritus of Rome Foundation, President of Drossman Center of Education and Practice of Biopsychosocial Care. Dr. Drossman is also Professor Emeritus of Medicine and Psychiatry at the University of North Carolina of Chapel Hill. He is founder of the Rome Foundation and is an internationally recognized scientist, clinician, and educator in DGBI and communication skills training. Today, Dr. Drossman is joined by our Rome Foundation board member, Magnus Simrén. Dr. Simrén is also the director of the Rome Foundation Research Foundation Institute, so RFRI. He is the professor of gastroenterology at the University of Gothenburg in Gothenburg, Sweden. Dr. Simrén is a senior consultant with the Department of Internal Medicine in Sahlgrenska University Hospital in Gothenburg. He is also connected to UNC Chapel Hill, just like Doug Drossman, as he is an adjunct professor of medicine at UNC Chapel Hill as well. I now turn things over to the esteemed Dr. Drossman for live Q&A.
Thank you, Tanya. Well, good seeing you again. From that introduction, we have a lot of opportunities to see each other at Rome, at UNC, in Sweden. For those of you who are not fully aware, Magnus has been a member of the board for, I guess, over 10 years now. And he's really distinguished himself by becoming the research director of the RFRI, which is a growing organization that's publishing lots and lots of papers. And he's also, perhaps relevant to this in some way, the co-director of the diet and nutrition section of the Rome Foundation, which kind of links to microbiome as well. Maybe we'll hear about that. So welcome. It's good to have you here.
Thank you. It's a pleasure to be here. And great to have a discussion about a very relevant topic tonight. That's fun to do that on a Friday evening, because it's Friday evening in Sweden right now.
Getting ready for the weekend. Well, this is a topic that can be rather confusing. We were just talking about that before. I sometimes think the more I learn about it, the less I know. We are talking about the microbiome, the microbiota. Maybe we should even understand what the differences are for that. But I think the main question is, what is the role of the gut microbiota in IBS or DGBI, other disorders of gut-brain interaction, and its clinical relevance? But let me append that by also saying, when I think about IBS, I think about microbiota. When I think about gastric esophagitis, I may not to the same degree. So maybe you can tell us the general question and whether you see differences by organ system.
Yes, I mean, sometimes microbiota and microbiome are used interchangeably, but some more when you talk about microbiota, you talk more of the microbes, where when you talk about the microbiome, you talk about the entire genetic composition, if you put it like that, of the microbiota. So but sometimes they are used interchangeably, these two different terms. And if you think about the gut microbes, the microbes that we have in the gut, we have fewer gut microbes in the upper part of the gastrointestinal part compared to the lower part of the gastrointestinal tract. So there are many more microbes in the lower part of the gastrointestinal tract, and also a larger variety of different types of microbes in the lower part of the gastrointestinal tract. So when you talk about DGBI, there are more studies and more knowledge about the role of the gut microbiota in IBS and constipation as compared to upper gastrointestinal disorders such as dyspepsia and esophageal disorders. There are a lot of studies have demonstrated that the gut microbiota are of relevance in patients with IBS and other lower DGBI. And we think that this happens through the interaction between the microbes in the gut and other factors in the gut, we can call gut microenvironment within the gut, such as interactions with food. And these interactions can then influence the function of the gut. And if there are alterations in the gut microbiota composition or in the function of gut microbiota, these interactions can then influence the function and lead to symptoms, etc., in patients with IBS. We don't know all the details about this because this is quite complicated to study this, but we know quite a lot, and we learn more and more from every day regarding this. And regarding the clinical relevance of the gut microbiota in IBS, we have several different clinical scenarios that actually can inform us that gut microbes can be involved in symptom generation in IBS. Probably the most well-known example is that the fact that roughly a quarter of, or 20 to 25% of the patients with IBS develop their symptoms after an infection. And this is called post-infection IBS. And there we have seen that this is associated with a change in the composition of the gut microbiota, and which stays even after the bug that caused the infection has gone away. So this is one example how changes in the gut microbiota can lead to symptoms. We also have another example when we take a course of antibiotics for an infection. That can lead to changes in the gut microbiota composition, and that can be related then to those symptoms that we may experience after a course of antibiotics. And then, of course, which we'll probably come back to, is the positive effects of different treatments modulating the gut microbiota, such as probiotics, prebiotics, and also we have the new kid on the block, fecal microbial transplantation, that actually can improve symptoms in IBS. So there are several different clinical scenarios that we can actually have as support for involvement of the gut microbiota in IBS in demonstrating its clinical relevance.
So it sounds like the bad microbiota with an infection or change in the flora with antibiotics is some way altering the mucosal integrity, maybe leading to greater transmigration of products or cytokine activation, or maybe have antibacterial other properties leading to nerve sensitization. Is that what we mean by post-infection?
That can be definitely one mechanism. I mean, the effect of gut microbes can occur through the mechanism that you alluded to here as well. But also there might be effects within the lumen. For instance, when the gut microbes interact with food, there are different products that are produced. There are gas production, for instance, that can lead to symptoms. So there are many different ways through which the gut microbes can lead to symptoms. And even influencing the gut-brain interactions, which is quite fascinating, that you can change the gut microbiota composition, and which can lead to then altered response pattern in the brain, if you put it like that. Yeah,
there have been some studies showing that the good bacteria can affect the good probiotics can reduce anxiety even.
Yeah, which is really fascinating.
How strong is this evidence? I mean, we hear about probiotics all the time. We talk about SIBO testing. When do you use these things, and how robust is the data?
I mean, the scientific evidence supporting the involvement of the gut microbiota symptom generation of IBS is relatively strong. I mean, but the majority of studies are what you can call association studies, where you can see that there is an altered gut microbiota composition and function associated with symptoms. But more direct, and we have these treatment studies where we actually can see that by modulating the gut microenvironment or gut microbiota, we can influence symptoms. And there is also a lot of animal studies where you have indications or proof that if you can change the gut microbiota, that can lead to to alterations in gut function, very similar to what we see in IBS. We can change the motility in the gut, for instance, the movements of the content in the gut. You can also make the gut more sensitive by changing the gut microbiota composition in animal studies. And hypersensitivity is one of the key mechanisms for patients with IBS. So we have a lot of evidence from human studies, but also a large amount of data from animal studies that can actually be linked to what we see in the human IBS situation.
So the average provider or doctor or gastroenterologist could get a little bit confused because there is some commercialization of this. And, I'm constantly getting patients who are bringing me these 20 or 30 pages of their gut microbiota because they've given a stool sample and they're asking me to recommend treatments. What's your take on these testing for stool stool bacteria, and moving on to that, the role for SIBO testing as well?
Yeah, when we start about the stool testing, I think that this will be something that we will be able to use in the future in clinical practice. Today, it's unfortunately not for clinical use. It's not standardized enough. We don't exactly know how to interpret the a big amount of data that you get from each patient with some bacteria going up and others going down. We cannot use that in a meaningful way for the individual patient. But I'm confident that in the near future we will be able to use it. But today, these tests are not useful in clinical practice, those stool microbiome tests that you actually can buy. I'm sad to say that. It would be great if we could use it, but we are not there yet. When it comes to SIBO, small intestinal bacterial overgrowth, the problem with the tests that we use, the hydrogen breath test, are that they are quite inaccurate in confirming or the presence of small intestinal bacterial overgrowth, because these are heavily influenced by transit. That is how fast the lactulose moves into to the large intestine. And if you have a rapid transit, which is the case for many IBS patients, this lactulose moves very quickly down to the large intestine. And then the hydrogen peak that you measure in the expired breath is then not a reflection of SIBO, but rapid transit. So then that leads to a false positive test. So therefore, I'm also quite reluctant to recommend testing for SIBO in the clinical practice. And from a practical point of view, I mean, the drug that we can use there, rifaximin, you don't need the lactulose hydrogen breath test in order to use that for the clinical indication that is there, namely non-constipated IBS. So I have the equipment in my lab to do this breath tests, but I only use them for research, but not for clinical use today. I know that that's different in different parts of the world, but I'm one of the skeptics about the use of these tests in clinical practice because of the poor sensitivity and specificity of these tests.
Yeah, we're on the same page. I mean,
yeah.
I don't have a lab, but if they have symptoms of bloating and diarrhea and IBS, and it hasn't been tried, because of the false positives and false negatives, I'd rather be guided by the clinical response.
Yeah.
So, and what about IMO? What about methanogens? Do you treat that?
That's even less. Proven that has a meaning. I mean, I also think that that's something where the role of the methanogens, for instance, for constipation, is something that we are studying quite a lot. But still, using this as a clinical tool is not meaningful today. I think this is a very interesting research area which we need to move further into and really understand what this means. But no, I don't use IMO to treat the patients with IBS. I use it. I mean, we have a lot of studies ongoing on that, but not ready for clinical use yet.
And should we be doing small bowel aspiration for to treat fungal overgrowth? which is, as you know, Satish Rao has published on that.
Yeah, I mean, again, I think this is highly interesting and something that we learn from these studies that are well done, but we don't really know the relevance clinically yet. So no, I don't do that in my clinical practice either. So there are lots of no's from my side in this discussion.
So let's get an overview then. How, in your practice and with your knowledge of the research, how do you use the microbiota knowledge in the management of IBS and other DGBIs? What do you do?
I mainly use it for, to support some of the treatments that I use. I mean, the knowledge about the role of gut microbiome is the backbone of why we use anti, pre, and probiotics to treat symptoms of IBS. That's the rationale behind that. I also use it quite a lot to explain how food can lead to symptoms in patients with IBS. We know the FODMAPs, these carbohydrates that are not absorbed in the small intestine but passed unabsorbed down to the large intestine. They can lead to symptoms through the interaction between these carbohydrates and the gut microbes through fermentation. So this is an explanation to patients how we actually, by reducing the FODMAP content of the food, can actually reduce some of the symptoms, and that is through the interaction between the food and the microbiome. And I also sometimes can use the knowledge from microbiome literature to explain symptom variations, which can be then related to changes in the gut microbiota composition. I can explain post-infection IBS through changes in the gut microbiome, and in general, I use the microbiome knowledge to explain symptoms to patients. I sometimes try to resemble the gut microbiota community in the gut with a society, where in a society you need a lot of different types of people, different type of professions in order to have a balanced and well-functioning society. And if, let's say, all the teachers disappear, then we'll not have a functioning society. And that's the same with the microbiome. If there are changes in the composition, the setup of the microbiome, then you can have changes in the gut function, and then that can lead to symptoms. And in a society with all the different functions, all the different professions, you can even harbor burglars and thieves, and still the society will function. And that's the same with the gut microbiome. You can deal with the bad guys, the bad microbes, if you have a good setup and good composition. So this is a way to explain how important the microbiome is and how easily subtle changes can actually lead to symptoms. So that's how I mainly use it in the discussion, the explanation, the communication with the patient, and also to support treatment.
That's very helpful. So it's still work in progress, but there is some hope that we could be able to target certain treatments based on the data that's accumulating in the microbiome.
Yeah, and the science is moving fast forward, and there are a lot of interest in the role of the gut microbiome, the gut microbiota in patients with IBS, and also moving into other DGBIs. There are also now more and more evidence suggesting that in functional dyspepsia that there are also changes in especially the duodenal microbiome. So that we can influence that with different type of treatments as well. Probiotics, for instance, there are some studies now with probiotics also in functional dyspepsia. We know that the use of PPIs, proton pump inhibitors, also influences the gut the duodenal microbiome. So also in these disorders that are previously less well studied when it comes to the role of gut microbiome, we have more and more data supporting its relevance there as well.
Well, thank you very much. Any last words or any final comments for the audience?
No, well, maybe that's. I'm pretty sure that we will have much more knowledge about this rapidly evolving field in the future, and I'm pretty sure that it will influence our clinical practice even more in the near future than it's doing today. So keep your eyes open.
Thank you. Well, if any of you have questions, send them to Tanya, and she'll convey them to Magnus and get back to you. Back to you, Tanya.
Very good. Wonderful. Thank you so much, both of you, for bringing your expertise today and talking more about IBS issues. Thank you, Magnus, for coming on all the way from Sweden today. We'll see everyone again next week on Friday at 1 p.m. Thank you.
Thank you. Bye-bye.